Hemorrhoidal veins that drain this area completely lack the internal valves that normally keep blood flowing upward. Furthermore, they pass right through the thick rectal musculature, which can pinch them shut during digestion. Without valves to support the vertical column of blood, the weight of intra-abdominal pressure pushes downward. Blood pools at the lowest point of these unsupported veins, stretching the loose connective tissue housing them. What we commonly call hemorrhoids are a direct consequence of this. They are the result of human anatomy yielding to chronic, compounding gravitational pressure. Because this system is constantly under tension, it takes very little to trigger an internal structural collapse. A low roughage diet often leads to straining, which adds a sudden, intense spike of downward force to an already vulnerable system. With each bowel movement, this downward force stretches the mucosal suspensory ligaments. Once they yield, the venous plexus is prolapsed below the anorectal ring, forming internal hemorrhoids. Due to blood vessel branching, these structural failures predictably occur at the 3, 7, and 11 o'clock positions. Occurring high up in the anal canal, these bulges remain covered by the bright red and purple mucous membrane of the internal anatomy, keeping the damage largely hidden from the outside. Straining isn't the only trigger. Any secondary biological event that adds intense intra-abdominal pressure, like a pregnancy or large uterine tumors compressing the superior rectal veins, can force this exact same internal collapse. Ultimately, these internal hemorrhoids are the direct, measurable result of suspended biological pillars buckling completely under this chronic internal pressure. The landscape of the anal canal shifts as we move distally down the anatomy, crossing a biological border called the dentate line. Below this line, the terrain changes. The sensitive internal mucous membrane ends, transitioning into standard skin at the anal orifice. This external zone takes the brunt of acute, sudden spikes in back pressure. Activities like violent coughing or holding your breath while lifting a heavy weight rapidly force pressure down into the tiny anal venules. When that pressure hits the exterior network, it causes a venous blowout in the perianal subcutaneous tissue, right beneath the skin. The trapped blood clots, creating a condition defined as a perianal hematoma or a thrombosed external hemorrhoid. Because this occurs under highly innervated skin, the physical presentation is immediate. It forms a sudden, painful, tense swelling lateral to the anal margin. The core structural issue remains identical, dilated blood vessels yielding to pressure, but crossing the dentate line creates an agonizing, exposed symptom profile. When a severe external rupture occurs, the direct engineering fix is mechanical. Under local anesthesia, a surgeon makes a small incision to extract the clotted halves of the hemorrhoid, instantly relieving the trapped pressure and allowing the tissue to heal. Diagnostic precision is vital because not every external protrusion indicates a venous failure. A sentinel pile, for example, often mimics the look of a hemorrhoid, but is actually the result of an anal fissure, a tear in the lining rather than a structural collapse of the veins. Zooming out, this entire biological system represents an ongoing clash between our evolutionary history and our modern habits. We took an internal plumbing system designed for walking on all fours and stood it upright. The simplest mechanical solution to prevent future collapse is to lower the daily strain on the system. Adding bulk-forming compounds and high roughage foods to a diet reduces the downward force required to expel waste, protecting the suspensory ligaments. For most patients, the earliest sign of hemorrhoidal disease happens in the bathroom. Painless, bright red bleeding that splashes into the toilet bowl during defecation. Because the bleeding looks dramatic but causes absolutely no physical pain, patients frequently ignore the symptom for months or even years. In this cross-section of a healthy anal canal, the internal hemorrhoidal plexus rests above the dentate line, secured by the mucosal suspensory ligaments, structural bands. Excessive straining creates high venous pressure, forcing these veins to engorge, stretch the mucosa, and painlessly rupture. Allowing this early bleeding to continue unchecked permits a progressive mechanical breakdown of the anal canal suspensory structures to begin. Before initiating any hemorrhoid treatment, a clinician must evaluate the patient using a sigmoidoscopy and an occult blood test of the stool. These tests are mandatory to rule out serious underlying diseases that also cause rectal bleeding, such as Crohn's disease, ulcerative colitis, or colon cancer. Once serious diseases are excluded, This early stage is diagnosed as a first-degree hemorrhoid. The internal vessels are engorged and actively bleeding, but they do not physically prolapse out of the anus. Baseline medical management focuses on relieving the pressure. High-residue diets and mild laxatives regulate the bowel to prevent straining, while topical ointments reduce local swelling and tissue edema. Physicians employ sclerotherapy for continued bleeding. A needle delivers a phenol solution into the submucosa at the hemorrhoid's base. This forces the vein to clot and shrink, then generates scar tissue that pulls the mucous membrane upward, locking it tightly against the inner muscle. Intervening at the first degree stops the bleeding by chemically reinforcing the structural integrity of the anal canal before the supporting ligaments are stretched permanently. As the untreated veins grow steadily larger and heavier, the mucosal suspensory ligament eventually gives way under the load, causing structural collapse. This milestone marks a second-degree hemorrhoid. The tissue now physically prolapses out of the anus during defecation, though it manages to reduce or pull back inside spontaneously afterward. By the third degree, the structural failure is so severe that the prolapse no longer returns naturally. The patient must manually push the tissue back into the anal canal, where it then stays reduced. A new primary symptom emerges at these stages: profuse mucus discharge. The mucous membrane is now constantly engorged and exposed, leaking fluid continuously. This excess mucus softens and excoriates the surrounding perianal skin, leading to severe pruritus ani, an intense and persistent itching. Reaching the third degree means the disease has shifted from an internal vascular bleed to a gross mechanical failure of mucosal support. At this stage, early treatments like sclerotherapy are strictly contraindicated. The final stage is the fourth degree. The hemorrhoids are permanently prolapsed, completely exposed, and can no longer be manually reduced. While pain is notably absent in earlier stages, it now becomes the dominant symptom as acute complications take hold of the exposed tissue. One major complication is external anal thrombosis, an acute, extremely painful swelling right at the anal verge, driven by high venous pressure. A dangerous mechanism is strangulation. The external sphincter muscle grips and chokes the prolapsed hemorrhoid, impeding venous return. Blood flows in but cannot escape, causing massive congestion. If arterial supply is also constricted, the starved tissue turns gangrenous, leading to severe infection. The fourth degree represents total mechanical failure. A previously painless bleed has evolved into a cascading surgical emergency that requires a full hemorrhoidectomy. Once the structural anatomy of a hemorrhoid is established and the suspensory ligaments are stretched out, the physical damage is almost never reversible on its own. However, early medical intervention is highly effective. Injection therapy applied to first and small second-degree hemorrhoids achieves a cure rate of nearly 95%. Understanding the staging of this disease allows patients to seek conservative management while the condition is still highly curable and completely painless. Proactive medical management halts the structural failure of the anal canal, successfully bypassing permanent prolapse, severe complications, and the need for invasive surgery entirely.
Rubber band ligation. Surgeons for years had been searching for a simple method of ligating hemorrhoids without the need for a general anesthetic or admission to hospital. Rubber banding is the ideal method of treating large first-degree and second-degree internal hemorrhoid in absence of associated tags or external hemorrhoidal component. Each hemorrhoid is visualized through a proctoscope. The upper part of the mucocutaneous line is grasped by an instrument and a small elastic band slipped over it. The upper part of the mucocutaneous line is grasped by an instrument and a small elastic band slipped over it. A recent modification uses a modified proctoscope with bands stretched over inner drum and pushed off by advancing the outer drum of the proctoscope over it. The tissue distal to the elastic band undergoes necrosis and excess mucosa in the anal canal is removed. The lower anal mucosa is drawn up by ensuing fibrosis, which adheres mucosa to muscle underneath. Rubber band ligation is done with little or no help, and it can cover larger piles than some options. The key is placement. Slide the band so it traps the base of the hemorrhoid at least 1 centimeter above the dentate line. If the dentate line is inside the band, pain can be intense. For each hemorrhoid, place 2 bands at once. This lowers the risk of secondary bleeding. After the bands are in, the ligated tissue usually necroses within 24 to 48 hours and sloughs off in about 7 days. The main downsides? Pain for the first day or two, sometimes very severe, and the possibility of secondary hemorrhage. You can band 1 or 2 hemorrhoids at a time. Avoid banding 3 large ones together, since ulceration can spread and lead to stenosis. If all goes well, you're reviewed after 1 month, and any remaining hemorrhoids are banded or injected as needed, then decide.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.